Live from New York, it's Benefits with Friends. I'm your host, Lou Bernardi, coming to you today from Woodbury, New York. Not a bad day here, probably in the mid 60s. Really excited for the show. We're going to try something a little bit different today. We're going to have Battle of the Benefits Specialists. I'm going to bring in two powerhouses that I've known for a few years, Nancy Giacolone, or just Giacolone. I'll let her clarify that. And Cristy Gupton, two amazing advisors from an organization that I'm part of called Health Rosetta. I'm a benefit advisor. I rebranded myself as the BOO a few years ago. So BOO stands for Benefit Optimization Officer, and that's kind of how I see myself fitting in with our clients. Help them optimize their benefits, not just buy insurance. I didn't like the title broker, consultant, advisor, and those are fine, but I think Boo kind of just fits a little bit more into the strategy here at our agency. It's called BrightPath, and BrightPath, it kind of doubles as our agency name, our DBA, and also our benefit strategy. So benefit optimization, as the name implies, is the process used by HR professionals to critically assess the organization's benefit structure and determine what changes can be made to make the benefit package on offer best serve the organization and the employees. And I think that's what we're all trying to do. A lot easier said than done. I think a lot of people, probably most companies out there, rely on their consultants, advisors, insurance partners for that type of information. And in my 30-year experience, far too often, the sole purpose is focused on buying insurance. And those insurance products are extremely important, but they're a little bit limiting in what they offer to people. And, we've kind of here at the agency kind of identified 8 core issues with the status quo. The first being a lack of price transparency, which we'll get into a little bit today with some of our questions. Lack of quality transparency, low provider patient engagement, 30% markup or more in prescription costs. Healthcare steerage is a big problem. Misaligned incentives of insurance carriers, agents, and most people involved with helping employers select their benefits. No controlled plan documents and unnecessary care. So without further ado, I am going to, well, first let me just introduce, and then I'll bring them into the studio. Our guests today, but our competitors today. We're going to have a fierce, fun and friendly competition, some questions to challenge the people out there, and also our two friends. Cristy Gupton, she is I think 2-time EBA Top Women in Benefits. Her fighting style is tenacity. Her hobbies are making jewelry. She's from her agency, and I'll let her talk about that a little bit more, is in, I think, 2 offices, one in North Carolina, one in South Carolina. And Nancy Giacolone, she's from Washington State. She's an EBA top women in benefits also. By the way, I have absolutely no awards or accolades, except maybe I have a #1 dad trophy somewhere. And perseverance and cooking is her hobby. So I'm gonna bring them both into the studio. Hello, Nancy. Hello, Cristy. How are you today?
Hey guys.
Great.
My mic is working, so that's important. I did 3 shows with no mic, so that for a minute or two. So I don't know if everybody has the same order as me, but Nancy, you're next on my screen. So if you want to introduce yourself to our guests out there.
I would love to. Thanks for having me, Lou. And I'm completely offended that somebody from New York does not know how to properly pronounce this mob last name of Giacolone.
That's okay. So I wasn't sure if the E, because I'm Italian, but I was like, is it Giacolone or is it Giacolone? Okay, good.
It's Giacolone, rhymes with baloney, in case you ever are at a loss for how to pronounce it.
Great.
Thank you so much for having me. Yes, I have a small boutique agency in Gig Harbor, Washington. I'm almost as far away in the country from you as you can possibly get. Mm-hmm. So we are definitely on opposite sides of the coast. And while you're having a lovely sunny day, I've got snow today.
Oh, wow. Very nice. Well, maybe not very nice. Nice for me, because I'm usually talking to people in California or Phoenix. I'm actually heading to Scottsdale next week just to get out of New York. But yeah, it's the weather's changed. It's definitely spring here now.
Yeah, it's been bizarre.
And Cristy, if you want to introduce yourself to people out there.
Sure. Hi, I'm Cristy Gupton. So it's 3 o'clock here in East Coast time, and so that means my kids are getting home from school. So if they if they interrupt our telecast, please forgive me. But I'm here in Western North Carolina, pretty close to Asheville. But the way the Carolinas are arranged geographically, the upstate South Carolina is pretty close too. So I'll just hold down the southern part of the of the situation here, and I'll say things like y'all and bless your heart if it comes to that. So
awesome. Well, thank you both for agreeing without knowing anything about what's about to happen, because this is our first, not our first episode, but our first fun competition. So I had this idea kind of after Health Rosetta Summit. I said, connected with so many great advisors out there who are doing unbelievable things, with their own unique style, right? And what's available in their market. New York is probably very different than Washington, different than North Carolina. We're a community rated state. So small employers are defined up to 100 employees. So, we can't sell stop loss. We can't self-insure. The rate's the rate, essentially, although we have discovered some things, and I've shared that with some of my other advisor partners, out there at some of these summits. But so we're going to get into the competition, and, we're not just going to go question by question. We're going to stop maybe and talk about these things a little bit. So let's start by, we'll have the question, and you can just blurt out the answer if you know it, and you get a point if you get the answer. And if that gets too out of control, then we'll have I'll flip a coin and we'll have a turn, and then it'll be like you could pass, or you can decide to answer it. And if you answer it right, you get a point. If you answer it wrong, your competitor gets a point. Well, we're making this up as we go along. So I think the next slide is the first question. Okay. What law went into effect in 2022 with the objective? Is that a B? All right. We got a B.
Is it bad manners if I interrupt you before the question's even?
Well, all right.
It's not like Jeopardy, right? Where you can
see if it's right. So what law went into effect this year with the objective of protecting people from unexpected out-of-network medical bills? So transparency in pricing, which is a law. No Surprises Act, which is a law. Compensation disclosure, which is a law. And the Consolidated Omnibus Budget Reconciliation Act, better known as COBRA. And I think that was from like 1970.
1986.
86.
Can I get a bonus point because Cristy got B, but I know the year that COBRA went into it.
All right, we're gonna give you half a point for that. So wait, let's see if Cristy got it right then. Let's see, and the answer is, of course, the No Surprises Act. Yeah. So for people out there who don't know what this is, you need to know what this is. So the No Surprises Act went into effect earlier this year and began protecting people with private health insurance from receiving surprise out-of-network medical bills when they receive care from an in-network hospital. However, more than half of adults 18 to 64 with private insurance say they know nothing about it, with an additional 1 in 5 saying they know only a little about it. So hopefully if you're in the business of purchasing benefits for your company, you've been made aware of it a little bit. So I don't know about you guys, but I know that one of the biggest things that I've run into over my career is that when someone goes into the hospital for a procedure and they get a bill from a department within the hospital, like an anesthesia department.
It's always the anesthesiologist.
Right. That's not part of that doesn't accept the same insurance as the hospital, because what people don't realize is they've departmentalized the hospitals, maybe for liability reasons, but maybe more likely
it was for revenue reasons.
It was for revenue reasons, and the anesthesia.
It was absolutely for revenue reasons. So the ER, radiology, anesthesiology, pathology, they've all been outsourced to companies like Team Health, Apollo, Envision, and it's pretty scary out there.
Yeah.
So we have to be really on top of that for our clients.
And the anesthesiologists wouldn't sign the contracts. They wouldn't sign network contracts because they could get more money by being out of network. So it was revenue on both sides. And we actually had this law in the state of Washington for about 5 years now.
Everything starts on the West Coast and moves east. You guys had managed care first. I was still selling indemnity plans in the early 90s, right? If anybody out there remembers what those were. But there weren't any networks, and that was interesting, being the young broker at the time, 30 years ago, to schlep through Manhattan holding 15 different directories, and then dumping them on someone's desk and them asking you, please don't leave them here, and then you had to schlep them back. They would end up in the waste paper basket. Okay, so I've made an executive decision. Since Cristy got the first one right, now it's going to be Nancy's turn to answer first or pass.
Okay.
All right. If you answer it right, you get a point. If you pass and Cristy gets it right, she gets a point. If she gets it wrong, you get the point.
Sweet.
There's some game show like that I've seen over the years. So anyway, question number 2. What percentage of U.S. adults has more than $250 in healthcare debt? Is it 4, 5, 9, or 33%?
D, 33%, Lou.
No.
Oh, $250?
I would have guessed 33%.
Okay.
Me too.
Right. So I think the $250 is the trick, but a lot of them have significant. Now, let's see what this says. A 2020 survey of income and program participation estimates that 9% of adults, or roughly 23 million people, owe more than $250 due to health costs. About half of those reporting significant medical debt owe more than $2,000. A small share, less than 1%, owes more than $10,000. And the group accounts for most of all medical debt owed by U.S. people. I guess that's the group of 10,000. So, yeah, I'm a little surprised by the 9% at $250, because we all know. I mean, it's a big percentage of people. We're talking about 23 million people having any kind of medical debt is a shame, right? It's I think that question was a loaded question to be very lopsided.
That's okay.
So yeah, I think that this is a growing problem because out-of-pocket costs have grown so significantly, right? The days of a $5 and $10 copay are long gone, and now we're dealing with way too many people having HRA wrapped around high deductible health plans, or HSAs, maybe even with no help at all from their employers. So, and couple that with the problem of a lack of assistance getting to the highest quality care is a real problem. I don't know if you guys want to add anything to that. Okay.
I don't know, but I was happy to see the announcement from the White House this week indicating they were taking measures, to help people with medical debt and investigating providers for bad business practices. So I think everyone should be on high alert, regardless of political affiliations.
Yeah.
I think this is a bipartisan issue that everyone should be pretty upset about. So I'm happy something is finally on the radar of those in Washington.
Yeah, absolutely. All right, question 3 coming up. Which type of bill, and this is for Cristy, which type of bill is subject to No Surprises Act protection? Is subject to protection under the No Surprise Act. A bill from an ER doctor not in your health plan, a bill from Amazon that was delivered late, a bill from a non-par lab that your PCP sent in error, a bill for a test not covered in your annual physical.
I'm going to go with A, Lou.
I think you might be right. A bill from an ER doctor not in your health plan. Yes. So the No Surprises Act limits what privately insured patients have to pay for covered services that they inadvertently receive from providers that are out of network. The law applies to emergency services, to non-emergency services provided in in-network hospitals and facilities, and to air ambulance services. I don't know that many people that have been in an air ambulance. There probably needs some protection in a few other places, but it's a
Air
big deal. I
ambulance
know
is
that.
terrible. Air ambulance is terrible. They have they're very proud of their services, and
They're in the
depending on
tens
where
of
you live,
thousands.
they can be ridiculous.
Is this, have you had any experiences, Nancy, with, yeah, wow. And this can be domestic too, right? So this is like you get in a car accident and a helicopter picks you up and brings you to the hospital. Would that be an example?
Yeah, it's pretty common in this area, especially because there's a specialty hospital that, and just the way that the geography is around where we live, air ambulance is a pretty common situation, and it always all the bills always have to be audited. They're terrible.
Are these mostly private companies?
Yes.
They are. Oh, definitely. I don't ever want to be in one. So I'll move on to the next question. So this is Nancy's question.
Better be an easy one, Lou.
Let's see. Okay, I think you might get this one. What is the term benefit advisors affectionately give to the 5 largest health insurers in the U.S.? Is it BOOCAH, 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 Boohoo, or cash cows?
Well, it should be D, but I know the answer is B, so we will go with B, BOOCAH.
BOOCAH, yes, of course. So the top 5 largest health insurers in the country are United Healthcare, Aetna, Anthem. I said those in reverse order. Cigna and Humana. We have to that's in order of size, by the way. That's based on membership. So, but we couldn't call them or whatever. So it's got to be BOOCAH. We just read. So I think it's a term of endearment for the most part. I never used it before 5 years ago when I kind of got out of the more traditional model. I was a GA for many years, and then I started hearing this term. I was like, what are they talking about? So I don't think we have to add anything more to that. All right, so we're 3-1. There's plenty of time to catch up. All right, Cristy, you're up. What is the annual cost of the most expensive drug in the U.S., I should add, in 2021? I'm not going to say these numbers. They're all very big numbers.
Yeah. I forget. Whose question is it now?
It's yours.
Yeah.
You could answer or you could pass.
Yeah, no, it's D. I mean, I even forget the name of the drug and what it supposedly cures, but it's D.
Let's say it is D. What was that number?
Zolgensma. Thank you.
$2,125,000. So Zolgensma is typically used to treat spinal muscular atrophy, SMA, a rare disorder caused by a defective gene. The illness destroys the nerves that control muscles. Zolgensma is delivered as a single one-time dose. So luckily, you don't need it every month. Single one-time dose to address the generic root cause of the disorder and ultimately produce long-term effects. Many people who take the drug show no signs of the disease in the future. Gene therapy is a patient-specific treatment that modifies one's DNA to change their genetic makeup. So it's amazing, I guess, what it does. It's not so amazing when someone has to pay for that.
I wonder what the efficacy
and then
of
what
that
if
is.
It doesn't work?
That's what I was going to say. I wonder what the efficacy of that really is. Yeah. What is the percentage of people that really helps?
I bet our buddy Pramod John has something to say about that. And, I don't know if anybody out there participates in captives, but I know one of the captives that I have a client in sent a letter out to everyone that says, look, we're just not going to play in that space. We're not covering gene therapies, period. And so, I imagine that this is just going to have to be done in academia. There's just going to have to be government money that creates all of these, what would you call, like clinical trials and programs and things like that, so that it's all handled in a space where they study this. No employer can really withstand that cost, not in any real capacity.
The thing about it is that it's a shock claim, right? It's not going to happen again. It's a single one-time dose, which is, which is fortunate. You mentioned captives, and I'm sure, maybe there's some stop loss carriers out there, even some insurance carriers. I don't know if it serves a purpose for them to decline it, but But sometimes by not covering it, it might open up opportunities to potentially even get it for free from the manufacturer. I've never looked up this particular one, but a lot. I would imagine probably most HR directors or benefit decision makers aren't aware that one strategy that's out there that really can only be deployed on self-insured accounts is excluding medications that are available free in some cases or at a significant discount from the manufacturer or another source, because they're not covered, right? Because there's incentives actually to get people to take medications. They don't promote them. You're not going to see that on the commercials. I watch a lot of Hallmark with my wife because I'm happily 30 years. In June, I'll be 30 years happily married. So it seems like every single commercial break is a specialty medication commercial, and they're spending billions of dollars advertising them. I'm not sure why. If they do what they do, I don't think you need to probably spend all that money. But anyway, all right. So 4 to 5. There's still plenty of time, Nancy. Don't worry. Here we go. Nancy's question: what strategies can be used to reduce prescription costs? Transparent or pass-through PBM model, better control of the drug formulary, international sourcing, or all of the above?
It's a tough one, Lou, but I'm going to have to go with D, all of the above.
Yeah, you might be right here. Of course. So unfortunately, plan sponsors that partner with BUCAs, those are the top 5 insurance carriers, or choose to be fully insured rarely have control of their drug formulary or the option to source medications internationally. Rebates, if they exist, and we know they do, on some really heavy-duty medications can be rightly returned to the plan sponsor instead of the insurer or the PBM if an employer works with a transparent PBM. And the only way you can do that, of course, is if you're self-insuring, right? So, the drug formulary is something that is confusing to a lot of people. And I think that I noticed, and I don't know if you guys would agree with me, but a few years ago, at least here in the Northeast, they stopped referring to the drug formulary as generic brand, preferred brand, right, and non-preferred brand, and they just started calling them tier 1, tier 2, tier 3, and sometimes tier 4, and then very strategic in doing that, because what people assume is that the tiers are based on the cost of the medicine always, and I'm sure that you guys know. And have some experiences. They're not. When you don't control that plan document or that drug formulary, your insurance carriers are strategically placing things where there's a lot of hidden profits, rebates. So the lowest cost drugs sometimes are in tier 2 and even in tier 3, or they get declined altogether in favor of more costly medications. And those rebates are kind of a gift to the insurance carriers for preferred, placement on the drug formulary. So I don't know if you want to add anything to that.
Sometimes if you look, you can even find generics in the specialty tier.
Yeah.
So it's quite a game they play with us.
It is. And it's a lot of money. I mean, for me, I always tell people, one of the huge advantages of self-insurance is control, but one of the least disruptive things about that change, if you do nothing else, is almost a guaranteed 25% or more savings on your drug cost if you're using a pass-through without all of the other strategies that can be implemented with self-insurance. As long as you're doing it with an independent TPA. If you're doing it with the BUCA-owned TPAs, they're not going to give you control of the formulary. That's for sure. All right, this is Cristy's question. Question 7. This is a challenging one. According to the Health Rosetta, which we're all part of, I believe, what major disease or procedure is most often misdiagnosed? Is it bypass surgery, new cancer cases, orthopedic surgery, or spinal surgery?
I'm going to go with B, new cancer cases.
All right,
I think
B.
that's an area where misdiagnosis is common.
All right. There's a couple of tricky ones in here. Let's see. It's spine surgery. New cancer cases actually, wow, 20%. Spine surgery, 67%. Misdiagnosed.
Bypass is at 60%.
Bypass, 60%.
Wow.
This came right from the Health Rosetta website, right? New cancer, 20. Orthopedic surgery, up to 30%. I saw a stat recently, 93% of spine surgeons would never have spine surgery. My mother has had 3.
Oh, wow.
My mother's had 3 fusions, and I'm not going to get into it, but it's kind of near and dear to my heart. It's yeah, this is a scary. I often joke that spine surgeons, run into parking lot and pull people out of parking lots to do spinal surgery on them. I mean, if 2/3 of the time they're misdiagnosed and you're getting surgery anyway, that is a real significant problem that we have here. So bypass surgery, maybe because new cancer cases, I'm thinking, Cristy, maybe a little bit more because of blood work, things like that, right? They're just a little bit more identifiable. I didn't look into the details of why, but all right, we're at 4-3 now, and it's
okay.
Whoa, I'm catching up. Watch out, Cristy.
What is Lou's middle name? No, I'm just kidding. Okay. All right. Which component isn't part of the high performance health plan blueprint of the Health Rosetta? Is not part? Transparent open networks, value-based primary care, hidden profit centers for payers and advisors, or independent active plan administration and oversight?
Well, Health Rosetta is very strong on not having any hidden profit centers for payers and advisors, so I will go with C.
That is correct. Of course they're not. So obviously that's kind of the status quo, right? Right or wrong. There's a lot of hidden profits, which hopefully will be addressed by the compensation disclosures and things like that. So quite the contrary, Health Rosetta was a driving force behind the 2020 compensation disclosure law that requires service providers, as their brokers, TPAs, et cetera, to disclose all direct and indirect compensation if it is expected to exceed $1,000 per year. FYI, the other components of the high performance health plan are transparent open networks, transparent pharmacy benefits, individual stewardship, high performance plan design, enabling technology, and transparent aligned advisors. Have you guys my account executive Lindsay has been sending our compensation disclosures out to all of our clients. We're working backwards from April to January, and they've been received very well. A lot of people have questions. What is this? Right? Well, why are you sending me this? What do I have to do with it? So, I'm kind of proud of being part of this organization. For the people that are out there that don't know what Health Rosetta is, I don't. It doesn't claim to be anything really. I think it's just an ecosystem of advisors, solution partners, TPAs, doctors. I mean, it's growing every day, of just really who are sick of the status quo, right? I mean, it's just I know I can't be part of it anymore, and that's what BrightPath is all about. And I'm sure that that's what your agencies and your whole approach, whether people want it or not, because sometimes the conversation is more than people expect. But anybody have anything they want to add to this question?
Well, I've been providing compensation disclosure for, I don't know, at least 10 years. And sometimes when I would give it to people, they'd be like, well, why do I care how much you're getting paid? I said, because you should know how much I'm getting paid.
Right.
And it's always kind of an interesting conversation. But yeah, I've done that for years. I'm glad that it's part of the conversation now. Although there's still games played around it, and don't let anybody fool you about that, because
of course,
especially if it's an agent or a consultant or whatever you want to call them that is servicing multiple lines. I've seen the fees buried in 401ks and fees transferred to other lines of business. And it's so ask the questions. If you're a client, if you're an employer, ask the question, ask if that's the only way you're getting compensated or if it's being offset anyway.
Right. Yeah, no, absolutely. Up till now, I mean, the 5,500, right? The Schedule A's would be really the only thing, and those only go out to employers that have 100 or more enrolled members on a benefit plan, right? And I've reached out to employers that, that just, when it comes across my desk and I see just something insane, like a 30% commission on stop loss. Like, why? On top of a 6% commission on the medical plan and 10% on the dental, and like, why? Like, why are you accepting that? And I guess it's just not enough. Hopefully the conversation around it will get the employers, the plan sponsors, to realize what is acceptable. The idea isn't to pay less, it's to get value for what you are paying, right? So for us, I know it's an opportunity for us to also kind of highlight, here's what we're providing you in addition to just helping them, secure the underlying health insurance plan benefits. Here's what else we're giving you, from compliance support and technology and onboarding tech, equipment, things of that nature. So, all right, we have a tie game.
Woohoo!
Getting later in the round. I don't know how many questions there were, but we have time here. So let's go to question 9. This is Christy's question. What isn't true of modern day partial self-insurance? What isn't true? It always requires health questionnaires. There's always the risk of a laser. The claims are the claims. So what can we save, or all of the above?
D, all of the above. I think that there's something to be said about all A, B, and C can be altered with smart consulting and working with all of your resources.
Let's see if you're right here. Let's see. Yeah, of course, it's all of the above. So what did we put in here? Alternative forms of underwriting, including capture data, can eliminate the need of health questionnaires. Stop loss carriers can include a new laser provision. However, high performance plan designs can help mitigate the impact of lasers, making them less costly than rate increases if handled with the attention they deserve. And any benefit decision maker who's reviewed medical and prescription cost analysis understands this is a false narrative about the claims being the claims. If you've actually, so what we're, our Bright Path approach is about taking the focus off the insurance and back onto the healthcare, which is really what you're buying for your employees, access to healthcare. Just that no one's been able to see, and I didn't see until 25 years into my career, and that's when everything changed for me, was then when I saw the price versus the cost, and even just the price for the exact same procedure at 2 different facilities.
Mm-hmm.
I actually was embarrassed because I was mad, to be honest with you, when I saw the data from some of the repricers that showed what a MRI cost versus charges here in Long Island. I'm not going to name any hospitals. I don't like to do that, but for $200 MRI, they're charging $7,000. Because of the discounts, they're probably going to collect, let's just round it off to 50%. They're going to get $3,500 for a $200 MRI, and you can get the exact same MRI, or maybe even a better quality MRI, a newer machine, at an independent radiologist a mile away for $600. And if you pay cash, you could probably get it for $400. That's another conversation, completely. So I'm kind of curious, because I know you guys have been in business for a little while. I'm not going to ask how long. That gets back to my first thing. I went right over it. So in the tail of the tape, height and weight, you never ask a lady. So that's not even in there, right? So, but I'm kind of curious, like what made you guys change your approach? Because for the people that are out there, these aren't just 2 average brokers that are taking quotes, orders, and seeing if they can beat your insurance plan. That's not what the people that I'm associated with and these organizations that I'm part of are doing. And that's why I love being part of it, because it helps me, just elevate my game all the time. But when did you guys see that behind the curtain or under the hood for the first time, and what was that impact on you?
I'll let you go first, Cristy.
I think it was I'm in North Carolina, not too far away from our buddy and friend that we all love, David Contorno. And so we didn't really compete against each other necessarily, but we did have a mutual client where I did part of services for that client and he did the main part. And so when we first met each other, I didn't have an appreciation for his style. Let's just put it that way. And I've told him this story many times and we all laugh over it. But he is the first one who started putting and planting seeds in my mind, because I would read what he would put on social media and think, dang it, I don't want to agree with that guy, but I do. And time went on. And in 2017, I listened to a podcast by David Saltzman, who interviewed Dr. Keith Smith. And it was all about transparency. And transparency is just one of my favorite things, because I feel like I'm kind of like Abraham Lincoln. I cannot tell a lie. It's just transparency is just a big deal to me. So David planted the seed. It got watered along the way. And then Dr. Keith Smith, made the seed sprout. And that was all kind of dating back to 2017. So,
Wow.
It's quite a journey we've been on, isn't it?
It sure is. Yeah, absolutely. How about you, Nancy?
Well, I've been in the business for 35 plus years, so I have been around for a while. But one of the things that has always been fundamental to how I've done business was accountability and common sense. And there were so many things that stopped making sense to me, and the insurance companies were no longer being accountable. And so, like Cristy, I started hearing about better ways. And even though I had done I've done self-insurance forever. I've done it for many, many years and understand the fundamentals. It still wasn't taking it apart, breaking it apart, and learning how to make the pieces function better to benefit the member and the employer. And as soon as I started understanding that, my sense of outrage grew about how much advantage was being taken of so many people in the system. And I don't like that. So
Right.
that's a big driver for me.
I'm gonna share something with you guys, because I have these cool glasses here.
That's cute.
So I'll tell this story with these on, even though I look like a fool. So when I first saw I was a GA, right? So I was a GA for 25 years. So I worked with hundreds, if not thousands, of brokers over the years. And, I was the specialist they were all coming to. And, of course, we were selling, Buca insurance products. And there's nothing wrong with that. There's nothing wrong with insurance brokers or things like that. And I intended to always be doing the right thing. And I loved going to open enrollment meetings. It's my favorite part of the year. Every time, I love being there with the people that I'm working so hard all year long for. And once I saw the prices and I started thinking about trends, and medical trend and all these different terms, and it was like when I saw the pharmacy prices and I learned about rebates and the spread pricing, and I had always felt like a superhero. That's why I have these dumb glasses on. I'll take those off now. I always felt like a superhero. How could I always get 20% down to 3 or 4 and and then get down to 0 or at least the low single digits every single time by tweaking the benefits. And then I realized it's all smoke and mirrors. There's so many hidden profits behind the scenes. And I got mad. And then my immediate reaction was all of those people, and I'm sure that this happens to you guys, and it happened hundreds of times over 30 years. I would always invite people. I would stay after the meetings, and the people that had personal questions that they didn't want to bring up in the meetings could come and ask me. And that's when the people who would come up and saying, you're increasing the copay on my prescription by $20 a month. It was 25, now it's going to be 45, and then 50 went to 75. And I'm already only taking 3 of my prescriptions a month now. I'll have to give up another one. And I then went immediately, I immediately went from feeling like a superhero to, You know, I was a poopy head, and really, and I get a little emotional about it sometimes because at that moment, and you guys know Free Market Medical Associate. I just connected. New York just opened. I had connected with them probably 2 years ago, but there wasn't a chapter here at all. There's not a lot of booze in this neck of the woods, I guess. And I reached out to them, and they connected me with Sydney, who actually runs the California branch, and New York, because he's from New York, but he moved out to California. And I connected with him, and we did a phone call. He was at the airport getting ready, I think, to fly to New York. And he asked me, he said, Lou, I got to ask you a question. Why did you reach out to us? You're the first broker I've spoken to. And I won't get into a lot, but, Free Market Medical is about sharing the prices. It's really about, helping people be smart consumers, getting them to the best doctors at the lowest cost, right? At a fair price, making people be able to be consumers for the first time. So anyway, that was my awakening, and really, a shift that I can't unshift. It's harder. We're trying to solve the pay more, get less with do more, get less for us, right? In essence, right? Working a lot harder doing it this way, but it's the right thing to do. So, all right. Question.
Shout out for the FMMA, the Free Market Medical Association, whose annual conference is coming up in May.
Yeah.
I'm lead the North and South Carolina chapter myself. So,
very nice.
Everybody go to fmma.org and get registered for the upcoming conference.
Yeah, I'll be at the conference board in Manhattan. Otherwise, Sydney asked me if I was going to go, and I have a prior engagement, but I definitely want to try to get to something in the future. All right, question 10. This is for Nancy. What does the acronym DPC stand for? Don't pick C, direct primary care, disclosed price contingency, or dependent primary contact?
Well, I think you had too much fun putting these questions and answers together because as evidenced by A, but we all know that DPC stands for direct primary care, which is B.
I'd be curious if there's anybody out there. I think there are. I see Mark Testa's out there. I can't chat with anybody, so I don't see anything, but I can tell you here in New York, they don't know what DPC is at all. There's one on Long Island, and I chased her down for 2 years.
There's plenty of doctors that I talk to who don't know what DPC is.
They don't. Well, in New York, there's literally one on Long Island, and a month ago, I signed my daughter up for her and went along with her. My daughter's 20, and over the years has had, several. Hey, Melissa, how are you? We got Melissa Hausler out there. Yeah, Hassler out there. I had tried to email her and call this doctor's office, not thinking she doesn't even have a receptionist because she doesn't need one. But she ignored all my calls. Like, why is an insurance broker calling me? I don't take insurance. And when I went with my daughter, Dr. Blyskell, I'll give her a shout out. It was amazing. We spent an hour with this doctor, which is 55 minutes more than my daughter spent with any doctor in her life. And my daughter has been on many, many medications. She has a lot of underlying health problems that we're hoping, that we can get to the bottom of. And, we're paying $90 a month flat fee to this doctor. This doctor doesn't take insurance. That's what direct primary care doctors are, right? They're doctors that are as fed up with the status quo, probably more so than us, because managed care has ruined a lot more than just insurance, employees' pocketbooks and employers' pocketbooks. Doctors don't want to deal with the administration. I think 80% of their time is spent on paperwork, probably. I know there's a stat. I should have put that stat in here, or that question in here. But we spent 90 minutes with this doctor, and within a week, my daughter had contact with her about 12 times. It was like the perfect storm. That week, everything was going on. And this doctor took over every medication. We didn't ask for anything. Who's the prescribing doctor? What's the pharmacy? I'll get this, I'll get that. We would have paid anything. I don't want to tell her this. Hope she doesn't raise my rates. I would have paid anything for this kind of attention 10 years ago for my daughter. It's not too late. She's going to be 21 this year. She's only 20. But, if you don't know about direct primary care, please reach out to Nancy, Cristy, or I. Be be happy to spend some time with you, because this is something that is crucial. I mean, this is, in my opinion, on the healthcare side of things, this has to happen. Without this, the doctors having the freedom to actually be doctors and make money fairly for their quality. I think I don't know how we get out of this mess that we're in. So I know, Cristy, you're a pretty big proponent of DPC.
Man, it's one of the best things. I think it is the best thing in healthcare right now. And so I'll put that claim out there. So I guess I'll do another shout out for a couple of other organizations. So the HINT Summit is coming up in June in Denver, Colorado. And then the DPC Alliance and the American Academy of Family Physicians, I think that's what AAFP stands for. Those two organizations are teaming up for their conference in Kansas City in July. And so if any of you guys out there have doctors that you like, encourage them to just go to one of the conferences and learn about it. I know at the very least, I'm speaking at the DPC Alliance Summit in Kansas City in July, and they have 3 different tracks. So they have like a 101 track for newbies and people kicking the tires, all the way up to a 300 track for, doctors who are really interested in working with employers. So I think every primary care doctor ought to at least learn about DPC and see if it is the solution to what even ails them.
Yeah. I was on a Forbes call with Forbes. Became a Forbes contributor earlier this year, and I was amazed at the attention all of these people. It's kind of like a finance group that I was in by default, I guess. Somehow there wasn't an insurance one, and when I introduced myself and I started explaining what I do, they were so interested, and it's because they're all in finance, and they said they see so much money moving into direct primary care behind the scenes. I don't think there's any slowing that down. I mean, and if you want to figure out what's going on in business, follow the money, like anything else. Follow the money if you want to catch the criminal. So, all right. So we're still tied. We're 5-5. I think it's Cristy's.
It is.
Question. Oh, all right. That was the answer. Oh, I didn't even we knew the answer. I didn't even show the answer. Okay.
Oh my gosh.
What is the typical claims corridor? 15% for self-insured only, 10% for self and fully insured plans, 25% for fully insured and 20 for self-insured, or 20 for self-insured and 20 for fully insured and 25 for self-insured.
Oh, Lou, you found my kryptonite. I am a lover of plan design, and stop loss is my kryptonite. It's my weakest link, but I'm just going to guess and say D, 20% for fully insured and 25% for self-insured.
Nancy's shaking her head. Yes. Yes. You're a good guesser. I'm going to go to a casino with you one day. So for the people that are out there that don't know what a corridor is, right? So it's also known as claims or risk corridor or margin. Underwriters include this as a cushion to cover unexpected claims. Generally, this amount is around 25% for self-insured plans or self-funded plans and 20% for fully insured plans. So your total expected claims plus the risk corridor for variable costs determine maximum liability or attachment point. So in layman's terms, every plan out there, whether you're fully insured or self-insured, starts with what are the expected claims based on that population, right? So if you have a 200-person group, they want your census, they get your demographics. Depending on how sophisticated they are, they use, age, gender, zip codes, family size, all of these different things. They say, all right, 200-person group, we're expecting $1.7 million worth of claims. We're going to add 20% to that. So that's $340,000 more if you're fully insured, 20%, because the insurance carrier, in theory, is taking the risk. So they're protecting themselves, right?
Well, fully insured is mandated too with minimum loss ratios.
Right. Yeah, no, absolutely. Right. So, but people don't realize that. They think, when I look at my loss ratio, I was pretty good. I was at 80%. well, maybe you aren't. You're actually maybe a little high. They want it to be what I usually say 65% loss ratio is really what they're kind of targeting, right? It just goes to my, my theory is it all starts with the claims, right? And that's why the whole approach is let's lower the claims costs, not by trying to pay less for insurance or claims, but let's get people the best health care. Because what people don't see is that the best health care typically is less costly, right? If we just weed out all of the hidden profits and the misaligned incentives and get people to the best doctor, best surgeon, best whatever, make sure they're seeing a doctor, make sure that people are filling their prescriptions. That poor lady, there's one particular person that runs through my head that was my nightmare for a long time. She's taken 2 out of 6 medications because she can't afford it. And what she is in my mind these days, she's a ticking time bomb to a $100,000, $200,000 claim, right? Mm-hmm. If we could find a way to get that person, and it's a person, right? A person. If we could find a way to get that person the medication they need to be able to take all 6 of their medications, they're going to have a better quality of life, and the claims are going to be lower. Over time, we're going to avoid what ultimately is going to become an outlier claimant, for that employer. So.
I agree with that, Lou, but I would like to also say that I think that we need to pay closer attention to, we talked about unnecessary medical procedures. There's also a lot of unnecessary prescriptions out there.
Oh, yeah.
Because oftentimes they come from competing doctors, et cetera, not competing, but, one doctor is not aware of another medication, and medications can have adverse interactions with each other. And we need to take a close look at the medications that we're taking as individuals, and also as helping people understand that it's okay to ask your doctor, why do I need this? What's the benefit? Is it going to interact with any of my other medications? And how long do I need to be on it? Because it's pretty typical for somebody to go to the doctor, get a prescription, and take it as gospel and think they need to take it for the rest of their lives. I mean, I see that often. And when we'll talk about it and they go back to the doctor, and they're like, oh, wow, you're right. I didn't know I could have been off of that long ago. So it is, the problems are systemic. I mean, they're from the member all the way through the payers, and we all play a part in the solution.
Yeah, no, that's the thing about the best doctors, right? They're not only the best at performing a particular surgery, they prescribe less, right? Mm-hmm. They don't jump towards medications. They look for alternatives, and they look, more holistically at the person and say, okay, we can do this, but let's hold off on that. Let's talk about your diet and appetite, right? Or exercise, so, there's a lot of different ways that you can go about this, but for me, it's about getting people to the best doctor at the end of the day. And that saves money if that's the goal of the organization, which it's really just it's the side effect of the way of the approach that we're taking. So, all right, Nancy, you're up.
All right.
Predetermined fees that are paid as part of a health plan, regardless of actual expenses, are called. So predetermined fees, this one, a little tricky, but not. Right? So predetermined fees that are paid as part of a health plan, regardless of actual expenses, are called commissions, retentions, fixed cost, or stop loss.
I'm going to go with C, fixed cost, because the cost of stop loss is included in that.
Right. A lot of these things are, right? So fixed cost is part of a fully insured plan. I mean, retention is. Commissions are built in. Stop loss if you're doing self-insurance is. So I believe you're right here. So yes, fixed cost. Fully insured plans are 100% fixed cost, paid out in a set premium rate to the carrier. Self-insured fixed costs range from about 18 to 20%, 21% of the total plan cost for administration fees and stop loss. Example of this could be TPAs fees, advisor fees, PBM fees, that's pharmacy benefit manager fees, stop loss, case management, telemedicine, nurse concierge, right? Those are fixed costs in a self-insured model if you're including all of those different things. So, all right. We're still tied. Let's see. This might be the last question and then a tiebreaker. So since we're tied, I think we should probably skip this question. I'll go to the tiebreaker. I like that. All right, so this is going to be a bonus. This will be a question for me. What state has the highest average family deductible? This is a free question. Everybody, if you want to guess, which state has the highest average family deductible? Family deductible.
California.
I'm gonna go with Georgia, I think, but I think this is a trick question.
It is a trick.
It's actually Arizona. That's why I skipped
That was my second. That would have been my second. It's California, Arizona. I knew it was a West Coast state.
I considered that one too.
Average, and this was based on a 2020 Kaiser, I believe, bank rate from the Federal Reserve data. Actually, that Federal Reserve data is the typical savings people have. So Arizona had the highest average family deductible, close to $5,000 on their health plan. California was actually last of those three. Kentucky, Georgia was second. But the stats as far as, so think about this in relationship to income level. So a typical couple with children that's 34 or younger has $3,600 in the bank of liquid money. But they have, on average, if they're in Arizona, potential exposure of $5,000 for their family deductible that year. 35 to 45 married with children, 10,000. Now this is the median, right? There's a lot of people with much less than that. I think 80% of the population has less than $2,000 in the bank. I just couldn't find that stat today, but I've seen it. And then a little bit older, 45 to 54, married with children, has $15,000. But every single year, this resets this out-of-pocket cost. It's amazing. And this is just the deductible. This isn't even maximum out-of-pocket. So, we have to start thinking about that when we're building these health plans. And, I know that you guys, Nancy, you have 5 years on me, but, it started with a zero copay on some plans here in New York, and 2. But I think 5 was probably the starting point for a lot of companies. Zero copay for hospital, drugs were free, and now we're at out-of-pocket costs. I think $7,000 is an individual HSA deductible this year, if I'm not mistaken. I can honestly say I don't have one client with an HSA, so I'm proud of that. We've been able to find other ways of saving and really helping to offer high quality benefits. But all right, so that was our free question. I think this is our tiebreaker. Okay. All right, so the tiebreaker question. So we've all seen this graph from Kaiser before. Here comes the glasses. Oh, I like that. All right, so this chart, I took the components off, right? We'll probably get 100 on this, but premiums and deductible rise faster than workers' wages over the past decade. So since 2009, here's 4 lines on this graph. Which one? I don't know how to do this. All right, so
I think that the 162% is premiums.
I think it's deductibles.
Deductibles, I think it's premiums. I would say premiums.
Okay.
I would say 20% is it's either earnings or inflation, and then deductibles would be 54% if I were guessing. So that's my guess. Okay, Cristy, you can rearrange them.
Full disclosure, I wouldn't have any answer, and I've seen this chart 50 times. As soon as I took it off, I had to go back to it every time to say, okay, which is this? So, all right, so we're going to end this in a time. I'm just going to share that 162% increase, because I remember the answers, is actually the deductibles.
Oh, Cristy, you were right.
Right.
I only know because I used this chart in a presentation at my Rotary Club last week.
Yeah. So deductibles have increased on average 162% since 2000. This was up to 2019. So there's been 3 more years. So it's probably 180% now. 54% increase in the family premiums. Now, keep in mind, though, we're raising the deductible to artificially keep the family premiums down. We didn't keep the benefits the same. If we hadn't changed the deductibles, then this would be reverted. We have 162% in premiums, right? So we're just
Right.
we're stealing from one hand to give to another. 26% was inflation, and earnings. Workers' earnings have actually increased 20%, which is insane. And where are all those earnings going? Into the premium.
To the deductible and the premium.
Right. And and that's the status quo. And that's that's what I'm sure that we're all fighting against is being able to, give this message to employers that says, all right, we know that this is complicated. You're not going to spend the time that the three of us have spent to learn everything that we've learned. For me, it's been really over the last 5 years breaking from the status quo. You can't do that. You're not going to be able to do that. But it still doesn't make it right to continue to go down the same road, right? Insurance carriers and the healthcare system are not going to change their way of doing business if the customer keeps coming back for the same old thing. And the only thing you can do with an insurance product is tweak the benefits. So you have to look at it differently and say, okay, this is only one tool in the basket. What else can we do? Who else can we work with? And I don't mean change your broker if you're out there. I'm not talking about that. What other supplemental tools can you do if you're not going to go self-insurance? Because when you self-insure the way we're talking about doing it most of the time, a lot of the tools are built into the solution. We're eliminating things automatically, but you can still do a lot of things with fully insured plans, not to the same extent. But for me, I don't know if you guys aren't from New York, so do you guys know who Cy Sims is? I never met the man, but I bring him up on almost every. Cy Sims had a chain of men's clothing. Well, actually, it was just clothing stores. I think it started as men's clothing stores, and then it grew. It was clothing stores, suits, tuxedos, dresses, blouses, everything. And his motto was, an educated consumer is our best customer. And that is the worst customer of the status quo. They don't want you to know the prices. They don't want you to seek out the best doctors or the lowest cost. They want nothing to do with any of the legislation that's been passed in the last year or two. Anyway, so I think that's it. So I'm going to go to there's the slide here. I'm going to bring this up here and then, where did Nancy go? I pulled Nancy out of this.
That's okay. I actually have a hard stop anyway. I need to pop off. This was a ton of fun.
Thank you so much. It was a pleasure. I hope you had fun. I know I had fun, and hopefully people out there had fun. Get in touch with one of these, unbelievable advisors. They can help you. They can help your company. And thank you, everyone. And talk to you guys soon.
Thanks.
Thanks,
Bye-bye.
Lou. This was fun.
Thank you, Cristy.
Bye, Cristy.
I enjoyed it.
Bye, Nancy.
Thank you, everybody. Bye-bye.